Hi, y'all. Welcome to the Tuesday Live. I'm your host, Dr. Dana Gibbs, your local thyroid and hormone expert here in North Texas. So today we're going to be discussing Hashimoto's disease, and this is going to be a deep dive, two-part series to help you get the latest facts on this often misunderstood condition. So if you're listening to this and you're not a doctor, this is not meant to be medical advice, and you should consult your own physician for any medical issues or diagnoses you may have. This is for educational and information purposes only. All right, Hashimoto's disease is one name for one of the two varieties of autoimmune thyroid disease. It is also known as chronic lymphocytic thyroiditis or just autoimmune thyroiditis, or even abbreviated AIT. It is the most common disorder of the thyroid gland here in the US. It is also the world's most common autoimmune disease by far. It affects about 15% of all Americans, most of whom don't even know they have it, and some 24% of allergic women. It is much more common in women than in men, and it can occur at any age. The most common onset seems to be in the teens to 30s timeframe. It does run in families, but about half the patients who find out they have it do not know of any relatives with the problem. Some triggers, or what we think starts it or causes it, are taking high levels of iodine, pregnancy, various infections, toxins, but in the most part, we don't really know what the trigger is, and frequently the disease process has been going on for years before it's even discovered. And it's frequently the first autoimmune disease that it presents in a person who may then tend to develop more and more severe autoimmune diseases later in their life. So Hashimoto's disease is also the most common cause of hypothyroidism or low thyroid function. But it can also cause elevated thyroid hormone levels or hyperthyroidism that come and go as the disease flares and then goes down again. Because of these bouts of hyperthyroidism, people who have it are frequently misdiagnosed with Graves' disease, which is a different autoimmune condition, and then mistakenly treated with surgical removal of the thyroid gland or with radiation treatment with iodine 131. It can also present at first glance with seemingly normal levels of thyroid hormones. This is generally called subclinical hypothyroidism, and I personally don't like this name because it implies that the people who have it don't actually have symptoms, which, as you will see, is not true. In Hashimoto's disease, the immune system has, for a variety of reasons, become allergic to the thyroid gland, or it thinks it's an organ that needs to be rejected. It attacks it with destructive antibodies that are targeted against the gland. The intended normal purpose of an antibody is to flag a disease-causing foreign agent that's in your body that needs to be destroyed by other cells and components in your immune system. In an autoimmune disorder, the immune system is producing rogue antibodies and immune cells that target healthy organs or cells or proteins in your body. In Hashimoto's disease, the immune system produces an antibody to a protein called thyroid peroxidase. This protein plays an important part in producing thyroid hormone inside your thyroid gland. Most people with Hashimoto's disease will have thyroid peroxidase antibodies detected in their blood. The other main antibody that is seen in Hashimoto's disease is thyroglobulin antibody, and thyroglobulin is a protein that binds and helps store thyroid hormone and transport it around in your bloodstream. So these antibodies and the immune cells that accompany them cause destructive processes to the tissues of your thyroid gland and sometimes release large amounts of thyroid hormone in the process. It spills it out into your blood. So if you know anything at all about thyroid problems, you probably know that our thyroid hormones set the rate of our metabolism, so how our bodies produce and use energy. So a person with Hashimoto's disease can be hyperthyroid, which is too much thyroid hormone, for periods of time. And this is sometimes called hashitoxicosis. They can then become euthyroid, which means they supposedly have enough thyroid hormone for a period of time before they finally become hypothyroid, which is not enough thyroid, as the destructive process of the thyroid gland continues and it can no longer make enough thyroid hormone. So in about 50% of people, the immune attack will go away on its own after a few months and never come back. Whereas the other half will gradually end up with various forms of hypothyroidism. And that's when most doctors will finally step in to treat with thyroid hormone. However, Hashimoto's can cause many symptoms before the gland actually becomes non-functional. And this causes a lot of distress for many patients because they go in and they get a test that shows that their TSH or the other thyroid hormones are basically normal, but they have all these symptoms. And most doctors do not know what to do about this. Anyway, these symptoms can include inflammation of the thyroid gland itself, which sits down here in the bottom of your neck. It can become swollen, tender, can make you have hoarseness. And then, as well as all of the symptoms of low thyroid function that we associate with a non-functioning thyroid gland. And the damage occurs by the infiltration of white blood cells or lymphocytes into the thyroid gland, which eventually replace the normal thyroid tissue with scar tissue. Now, sometimes the gland will recover and start producing thyroid follicles again. If that happens in the presence of that scar tissue, it can produce nodules in your thyroid or even a goiter, which is a frank enlargement or swelling. And these can get really big and they can be mistaken for thyroid cancer. So it is important to do the DNA testing or genetic testing on a thyroid nodule specimen if it's done if a needle thyroid test is done, to make sure that it's malignant before you go and take it out, because these tests will show something called HURTHLE, HURTHLE cells on the biopsy, and those are the inflammatory cells of Hashimoto's disease. Another thing that can happen is that the antibodies can actually block the action of TSH, which causes your thyroid gland to actually shrivel away or atrophy. And that's pretty uncommon, but still notable. So then what is this subclinical hypothyroidism? So patients who have Hashimoto's antibodies or Hashimoto's disease generally do not efficiently activate and process their thyroid hormone, even if they have enough T4 to make the active version T3. And I've talked about this in other lives, so you can check out my blog if you're interested in what's going on in when reverse T3 gets high. So this can be the case with normal TSH or elevated TSH and normal free T4 levels, and that's the definition of subclinical hypothyroidism. And patients with subclinical hypothyroid symptoms will frequently have some or many of those symptoms and will feel worse if they are given levothyroxine. The reason for this is that high T4, which is the storage form of thyroid, feeds back to the control mechanisms in your brain and pituitary gland to reduce the conversion to the active form T3 even more than it already was. And T3 is what drives the metabolic processes and makes us feel well. So I've done a whole other blog post on subclinical hypothyroidism. You can check that out on my website. Or because of the large fluctuations in thyroid hormone that happen early in the disease, these patients can end up with really high levels of reverse T3, which is a blocker of the T3 active hormone. So even if they have enough T3, they will feel like they don't. And that production of reverse T3 is actually a defense mechanism by the body to guard against wasting your energy stores from too much metabolic function in times of extreme physical illness or famine, or in the high levels of thyroid hormones that are seen in the setting of hyperthyroidism. So in Hashimoto's disease, that elevated reverse T3 will cause all the same hypothyroidism symptoms, even when the rest of your labs are completely normal. And I see this happen all the time. So how are we going to diagnose Hashimoto's disease? So if a patient is experiencing several symptoms of hyper or hypothyroidism, or a swollen thyroid gland or a tender thyroid gland, they need to get examined by an experienced doctor and get lab tests performed. And Hashimoto's disease can present with an enlargement of the thyroid gland or with a thyroid nodule that's found on a routine exam. And it'll typically have a pretty firm and rubbery feel, or even a gland that feels like it's missing. Lab tests for suspected Hashimoto's disease and thyroid dysfunction are as follows: free T3, free T4, TSH, total T3, reverse T3. These should be tested all together and at the same time every day, each time the tests are repeated. My personal preference is in the middle of the day for somebody who's already on thyroid hormone. These have really very tight ideal ranges within the normal reference range as given by my lab. And so you can have normal and not ideal. And then the ratio of total T3 divided by reverse T3 is a really excellent indicator of either dysfunction or healthy thyroid function. And levels between 10 and 14, are the really ideal level, but some people feel better even higher than that. And if that ratio of total T3 divided by reverse T3 is lower than 10, that indicates an inadequate availability of free T3 to your body to promote your metabolism. So the other tests that you need to do are the thyroid peroxidase antibody and then the thyroid globulin antibody. And these should be tested at least once to verify the presence of autoimmune thyroid antibodies. However, a negative antibody test doesn't totally rule out Hashimoto's disease because of it being a primarily cellular process. I generally don't repeat these tests often, but it really can give you an indicator of whether your lifestyle changes and your other treatments are helping to control the inflammation that you have. There's one other test that I recommend be done one time, and that is the thyroid receptor antibody or thyroid stimulating immunoglobulin. There's two different tests. They basically test the same thing. And that's to test if there's hyperthyroidism, for making sure that what you have is not actually Graves' disease, because people with Graves' disease can also have those other thyroid antibodies. What about treatment? What can we do about Hashimoto's disease once you have it? Well, there are a variety of options for treating Hashimoto's. Most internet sources that are sponsored by major medical institutions will say there's no need to treat until your thyroid function is inadequate. This is a huge problem because many doctors still believe that you can determine thyroid function with the TSH or thyroid stimulating hormone test by itself or with the free T4 levels. And newer studies are really showing that this is not the case. And I'm going to talk about that more in part 2. So I'm Dana Gibbs. I'm an integrative physician in North Texas. I'm a thyroid hormone and Hashimoto's expert. I help you learn things about your thyroid and other hormone imbalances that your doctor may not even know. So if you want to learn more, check out my website at www.danagibbsmd.com. There are lots of free resources in my blog and some videos there. And I hope you enjoy taking a look at those. All right, that's it for today. Thanks for listening, and I'll talk to you again soon.